Where some mothers may obviously say that some women, I mean, the reality is that, I guess if you are struggling yourself and perhaps you're saying you don't have the capacity to feed yourself well, but I do think maybe breast milk, not breast milk, contained milk may be more expensive. But I think we have to look at it as a social issue, obviously, but as also from the Ministry of Health, what are we doing to encourage breastfeeding at the community level, to support breastfeeding, recognizing seriously that this is perhaps one of those things, one of those unspoken variables that determine whether or not we continue to face an NCD crisis. And so I would just like some direction on that, please. Thanks.
Thank you, member. It is another area that the ministry is focused on. Generally, the QEH, the polyclinics, it is a general focus on that, and of course the nutrition department, the importance of breastfeeding. I'm going to ask the chief medical officer to speak to this first, and then the chief nursing officer, because there's quite a bit going on.
Yes, thank you, Kenneth George, CMO. The Ministry of Health policy is exclusive breastfeeding for the first 6 months of the infant's life. We have always maintained that approach. We cannot legislate a breastfeeding policy. So what it requires us to do is more moral suasion, public education, and engagement. The other issue, along with breastfeeding, we need to be able to resist marketing of breast milk substitutes to mothers, because one of the pressures not to breastfeed is that it may be easier for some mothers to use breast milk substitutes, which frequently affect the baby's ability in the long term with respect to some diseases and their ability to fight certain infections. This is a typical requirement. Breastfeeding is in the mode of the public health nurse, and one of their required functions is to make sure that breastfeeding is well established in the postnatal period. But further to that, the Queen Elizabeth Hospital was a few years ago certified as a baby-friendly hospital, in which the mother, the baby was put on the mother's breast within, I think, half hour of birth. I think we might have lost that designation, and we need to work hard to recapture that designation again. But it starts with policies and programs within the Queen Elizabeth Hospital, and also the transitioning that the public health nurse ensures that particularly young mothers, high-risk mothers, etc., understand the concept of breastfeeding. I will stop there, and I will ask the chief nursing, the director of nursing services at the QEH to speak on the recognition of QEH as a baby-friendly institution, and the chief nursing officer with respect to their roles and obligations to the public.
Good afternoon again, Anastasia Jordan, Chief Nursing Officer. Breastfeeding is indeed an important aspect when it relates to monitoring and the whole ideology of how it impacts in terms of obesity. We've seen studies that have actually related and correlated that it does have an impact. You have to be cognizant of the fact, though, however, that we are dealing with a different generation that sees quickness and the whole notion of preparing bottles rather than doing what we would like in terms of breastfeeding, but we are still pushing breastfeeding. Public health nurses usually have ongoing sessions, not only postnatally, but antenatally, encouraging mothers to use breastfeeding, not only for the purpose of nutrition, but for bonding. So we have better establishment when it comes to the relationship between mother and child, and it is also pushed postnatally, looking at the economic costs that it also benefits in terms of reducing the amount of money spent on baby milk. I also say, as a nurse, you do not see any other animal in the world buying formula. So it is something that we normally push, and it's something that is concentrated a lot on primary health care. And our public health nurses are well known for doing this, going out in the communities, helping young mothers who have challenges when it comes to breastfeeding, because there are many challenges you can have when it comes to breastfeeding. But as it relates to the baby-friendly status of the QEH hospital, this program was done a long time ago, and we are still maintaining it. But I'm going to ask the Director of Nursing Services at the QEH to elaborate a bit more on how we plan to sustain and reestablish the program.
Henderson Pinder, Director of Nursing Services, Queen Elizabeth Hospital. I want to just say to this August group that breastfeeding is one of the fundamental changes that we can make in Barbados' policies that will affect our future generations down the line. The benefits of breastfeeding have been well researched and published, and there are important indicators that help us to understand where we're going as a nation. The benefits have been already elucidated here, but what we can tell you for sure is that it is a process that begins way before, sometimes in the mind of the mother, way before the prenatal stage. And we want to get that kind of education out there where persons understand that it is from the time you decide that you are going to get pregnant that the decision should be made, or we should encourage our mothers to make that decision from that stage. So we are pressing on in this process. At present, we are still maintaining our baby-friendly accreditation. But however, we are scheduled to go back for recertification in the very near future. We have sought assistance from the Pan American Health Organization, and they are going to be working with us to help to establish some of the criteria that we need to see and meet for the accreditation to continue in the future. Additionally, we have brought on board one of our former nurses who was integral in the breastfeeding arena, and who has been a assessor and a facilitator in all the other hospitals throughout the Caribbean who have been accredited. Let me say that this accreditation, we take it for granted, but it's a very important accreditation, and many hospitals throughout the world are struggling to meet this accreditation, and we have been able to do it successfully for a number of times. And we are hoping in this present iteration that we will be given a certification, because we've put the processes in place. We are having meetings with our stakeholders. We have a meeting with the Ministry of Health. We have meetings with PAHO. We will then go into the community and spread it to all the stakeholders that when it comes to the time of implementation, every member of the community is aware of the benefits of breastfeeding and can help in this process. Additionally, we want to target our males. We are asking men, wherever you are, to support the women in their drive towards having the baby breastfed for 6 months on breast milk only. That's an important factor. And then the other thing would be to help in terms of our workplaces, to encourage workplace compliance with some of the criteria that are needed for this venture. I see us working together in the very near future to see a full implementation and reaccreditation of the breastfeeding policy.
Thank you so much, Senior Minister. In my mind, these two questions are very related, and I think we have to get this right. I really do. I think the potential for Barbados to lose all of its progress could happen before our very eyes without us recognizing. I think this breastfeeding issue is tremendously important. I know we're about to do a parenting program. A part of it includes conversations on breastfeeding and working with the foundation that is the community-based foundation to do some of that work. Also know with the Ministry of Health, I would hope. But I think if we can get this right, we would have less persons depending on the social services sector. I think we're going to have less problems in the education sector. We have to see the dots and connect the dots, because we only see these things when they manifest themselves 20 years down the road. But the truth is we need to get this program right. The accreditation is extremely important. And I would just close by saying we're about to launch a PR program called Share the Care through the gender unit. And I think as I listen to you speak about the asking men to come forward and to help, part of sharing the care, and to do so reasonably, because sometimes men can have unreasonable responses to these things, to do so reasonably and to allow us to be able to build a better Barbados. But so I want to thank the ministry, I want to thank the staff for their responses, and I think they're doing a very good job. Thank you very much.
Thank you. Thank you, Honourable Member.
Honourable Leader of Government Business.
I promise to be short, Mr. Chair. I know, Minister, the team has been in the well for some time. But as I said on the outset yesterday, there are a number of pressing issues that I think members have brought out in the course of this debate, but that I wanted to put on the table as well. I know that the estimates speak to improvements to the Sir Winston Scott Polyclinic. We refer to it often as fast track. I recall a few months ago I had the experience of having to go there with a young lady who had fallen ill, and was, had the opportunity to, walk around and notice certainly that the surroundings I found were not necessarily the best in terms of there's no pictures on the wall, the place wasn't well lit. I'm not sure what the cost that is in the estimates are specifically for in terms of the improvements, but really to say that, well, these are places where people go because they are sick. I think that we have to pay attention to the infrastructure and the aesthetics as well while people are also there. So my question relates, first of all, to what are the improvements being made? But secondly, I found on that occasion with the young lady that having left the fast track system, because there were only certain things that could be done there, the young lady had to go over to the accident and emergency. And having taken certain information at the polyclinic, the same information had to be taken all over again over at QEH. And I'm just wondering, where are we in the process of, for instance, the digitization of the records, and more specifically being able to, not have to go back through that process every single time that you go to one of the institutions?
Thank you, Honourable Member. It's two questions I see here in terms of the state of the walk-in clinic, the 20 Winston Scott, and the work that was needed. I'm kind of sure that a lot of work has been done, because you also had industrial issues there. They had over Christmas time, I know they had shortage of staff. These matters being addressed as best we can. And certainly as it relates to staffing, I know that there's been, recently we got permission to hire, I think it's 10 clinical medical officers. So the staffing, the medical staffing should be adjusted now, can be adjusted. Mr. Haynes can speak to the work that has been done there and has to be done. And the matter of the digitization and all that, we covered yesterday, but I'm going to ask Minister Ishmael to give an overview of what we've done and what we're planning as it relates to medical records, digitization, and health information systems. Thank you.
Chairman, Greg Sahin, Senior Technical Officer, Ministry of Health and Wellness. With respect to the honorable member, with the work going on at Vincent Scott Polyclinic, currently we are doing some major upgrades with respect to painting. We are about 3/4 complete with respect to that. We have some challenges in that we are trying to manage doing the works without hindering the services at the clinic. However, we will continue to work at its best to get these tasks completed. With respect to upgrading many of the spaces as well, we would have introduced some upgrades to the wound care room, the cubicle spaces the nurses occupy by cooling the spaces with ACs, upgrading the electricals. We would have dealt with some poor drainage issues on the roof that would create some leaks as well. So we realized Vincent Scott is most unique because we categorize it as a mini hospital. And the objective of the ministry is to put a specific focus at that institution, while executing work not to halt the services, but to improve overall service at that facility.
Thank you, Honourable Member, for the question. And we would have referenced previously in this discussion the procurement of the health information system. And the health information system will do exactly what you would have alluded to in terms of being able to follow and track a patient from one part of the health network through to the other. The ministry has a vision that through the procurement and the implementation and rollout of that health information system, that wherever a citizen of Barbados interacts with the polyclinics or which is primary care all the way through to the hospital, from accident emergency all the way through to the wards, that electronic record of them would be able to follow them wherever they go. Now, there are reasons why, clinical reasons, and I'm not a doctor, but there are clinical reasons why a person may be asked the same question multiple times across the various stages of their journey throughout the hospital. I believe it helps with ensuring that you have the right person that you're dealing with. That is a very important part of the process. But we do understand that sometimes there can be repetition because there is really no digital record that would allow the clinician, the doctor or the nurse to be able to get the information at their fingertips. So the health information system and the digitization and digitalization process that we're undertaking right now of the QH IT project, which, as I said before, is a 30-month project, is really designed to get us to the stage where the QEH and the rest of the health network is performing at a far more advanced, technologically proficient level. So I believe that as we go through this process, we're right now, and just to give a further update on where we are, we have already started a robust and comprehensive needs assessment. The needs assessment is very technical. It allows for the team, the project team that's leading this process, it allows them to go into every specific department at the QEH in particular, that's where we're starting, and to see exactly what technologies are currently being used, what services are currently being rendered, what are their current processes, and how do we then re-engineer those processes, and what solution that we're going to go there to procure, how are we going to match those needs to the solution that we're going to bring and implement. So that needs assessment is comprehensive, is already underway, and I believe within the course of this month of March, that is going to be completed, and then during the course of April, we're going to continue with the development of an RFP and go through the process towards procuring that software platform. Once the health information system is procured, that will then help us to be able to start to connect all of the dots throughout the system, and there's a technical word, interoperability, that allows all of those various parts of the QEH and the health network by extension to be able to speak to each other, and therefore affording every single citizen the opportunity to have their records going wherever they go. I envision, and also, yes, and by extension, the private sector as well. So in other words, we envision a Barbados where citizen Joe can walk into his polyclinic, his or her polyclinic, well, Joe, walk into his polyclinic, or go to his private GP and be able to have his health record pulled up there. He could have prescriptions administered, and he can then, if he has to, interact with the accident emergency or to the QEH on a ward. That same information can be pulled up on the same health information system. All of it speaking together, all of it being updated in real time, all of it being very secure, robustly secured, so that we don't have data breaches and different things like that. But of course, we make sure that any health information system has robust cybersecurity attached to it, so that that data and that information can only be accessed by who is supposed to access it, with the relevant permissions being given by the citizen. So in a nutshell, that project is well underway, and we believe that within the next 30 months or so, even less than, we should see the health information infrastructure of the QEH enhanced significantly and beyond QEH towards the rest of the healthcare system. Thank you.
Good afternoon. I want to address the issue relating to the infrastructure that the Honorable spoke to relating to the Winston Scott Polyclinic. Very soon, there'll be more or less a facelift of the exterior walls of the polyclinic, where there will be a mural that will be placed on the walls. Now recently, a mural to be placed on the exterior walls. Most recently, I had the opportunity to review the pictures for the mural, and we're currently in the advanced stages of preparing to have that placed on the exterior walls. Also, within the next couple of days, there'll be work done in the polyclinic of itself, where the floor will be resurfaced and replaced, and some additional work to its interior. So we are cognizant of the need to upgrade the polyclinic, and that is being done as well. I also would like to mention that there's going to be, under the Saudi Development Plan Fund, there's going to be relocation of 2 polyclinics. Those are the Newlis Gibson and Randall Phillips, and then the other 7 polyclinics are going to be refurbished. So we are quite aware of the need to refurbish and relocate the polyclinics. So in addition to Sir Winston Scott Polyclinic, the others will also be addressed.
I want to thank you for that, Minister, and those who spoke. It means that you are listening, both in relation to linear accelerators and also in relation to the improvements at Sir Winston Scott. So I would take it that my comments to you have not been in vain, and I appreciate the fact that it has been included in this year's estimates. The other question, though, that I have relates, I know we've said a lot in relation to human resources at the Queen Elizabeth Hospital and throughout the system, and provision has obviously been made in this year's estimate specifically to deal with it. But one of the things that I would like us to just zoom in on specifically is as it relates to, first of all, the accident and emergency department. My understanding is obviously that there had been some challenges in relation to doctors, particularly being able to do the assessments after the nurses have done performed their role, and to be able to have the specific doctors there to be able to evaluate and then to assess those persons to send them on to their other cares. But one of the things that I'm not sure about is whether we have already addressed it or whether these estimates are taking that into account. And then secondly, as it relates to A&E, because that is the place where most people go for the initial intervention, is whether we have addressed the issue of the on-call doctors. Because I have recognized that from personal experience that if you get sick in the middle of the night, oftentimes, despite speeding up now of being able to have certain tests done, radiological examinations done, what often happens is that sometimes the results are not read until perhaps the next morning. Meanwhile, patients are obviously waiting for those results to be read. So have we actually addressed the issue in these estimates as well in terms of improvements to on-call doctors and having those persons really be on call? I know that other colleagues would have raised the issue of a 24-hour hospital. And obviously, if we move in that direction, a lot of these issues will be put behind us. But what are the steps being taken for this year to be able to ensure that on-call really means that the person is sitting, waiting, whether in Barbados or some other part of the world, to be able to respond and to give doctors here in Barbados who are dealing and interfacing with the patients real-time information so that action can be taken almost immediately in relation to patient care?
Thank you, Honourable Member. I'm going to speak to some of these, and then I'm going to ask Dr. Anne-Marie Cruikshank, who is in charge of A&E, to probably speak to it too. Obviously, I said yesterday that there's going to be an expansion, plans for equipment. All of this we have taken consideration of. Specifically, the matter of on-call. As I recall, doctors working in accident and emergency work overtime. I don't think it has changed. I am not certain when you speak of on-call, we speak of the doctors who work in the wards, who oftentimes are required, patients are waiting there to be reviewed by these on-call doctors.
I'm speaking about the persons who read the results, so like radiologists specifically.
Radiologists and the lab
but to your point, I think there's also the part that most people don't see, which is the other floors where patients are waiting to be seen by consultants, for instance.
Right, that's what I'm speaking to.
And whether that has also really been addressed.
Because we, as part of the HR agreement, we're supposed to get additional registrars for the medical floors, because that is usually the major problem. The staff in internal medicine We are supposed to get the additional registrars that have been asked for to try to alleviate that. The matter about the space will be doubled. The recurrent factor will often be, however, the elderly for care, who are going to be there, you get rid of them and they come again. The matter of lab, and there's been discussion about getting point of care machines to do some tests there at the bedside while we continue to work, but the lab techs are paid, some are on call and some get overtime. That has to be sorted out, the logistics of that. As it relates to the X-ray, we are looking to put a CT scan there. Oftentimes that is a tremendous delay. I think you know that, especially with people with strokes. So having an X-ray, a CT scan there, that is expected to cut out that with you. You'll get the staff that you need to run it 24 hours there. So that should be somewhat eradicated. They're proposing to get additional staff in all categories. Doctors, specified doctors that are specialized in accident and emergency, who have finished their training. Nurses, they've got requests for orderlies, additional orderlies. So all categories of staff in the A&E are supposed to be addressed. I don't know if Dr. Cruikshank wants to speak a bit more.
Good afternoon to the Chairman. Good afternoon, Minister. As respect to what the Honourable Minister said, with respect to the on-call, we've had some challenges with that, as you would have known when you've passed through the accident and emergency. And we're putting some proposals.
Officer, we didn't hear your introduction too clearly.
Sorry.
Your name and your
Please excuse
position.
me. Dr. Anne-Marie Cruikshank. I'm the head of accident and emergency. As the Honourable Minister would have mentioned, we are looking at on-call. On-call is with respect to the doctors that work on the ward. So it's not really part of accident emergency. But if we're moving to a 24-hour hospital, we are now looking to see that hiring more consultants, which may be present in the accident and emergency on a 24-hour basis. So we've requested 2 additional consultants to be part of our team. Also senior registrars, which will give us more coverage with respect to senior cover in the accident and emergency department. Also other categories of staff in terms of departmental aides, orderlies, more nurses, more nursing assistants, where we can get a greater coverage for the patients. As you know, we are currently short-staffed, and a lot of nurses and doctors, sessional doctors and flexi nurses have to come to assist. So I think staffing is something we're focusing on, extremely important in the accident and emergency, to move towards this 24-hour hospital that we're hoping for.
Thank you, Minister. Thank you, Dr. Cruikshank. And I just want to say that for the record that I have seen the improvements at QEH in terms of especially A&E in relation to the infrastructure. I know during COVID we would have spent a lot of funds to be able to improve the spaces there. I know there's still a lot more works that are ongoing. There are still improvements to be made, obviously, in terms of the delivery of service. But I think as somebody who has been through the system there on many occasions, I personally can say that I can see money well spent in terms of the improvements. And I would just want to encourage the staff at the hospital, and certainly you in particular, Minister, while the criticisms may come, I think we have to keep focus in terms of the transformation that is necessary, providing the relevant staffing in particular to the departments and of course the equipment. And so my last and final question relates to 2 things, the PET scan machine, and also relates to genetic testing. I could not leave this debate without asking for an update on either of these 2 things. PET scan machines as it relates to the ability to be able to help persons to know whether cancer has spread, because that helps people to make decisions in terms of their future. And I'm finding that a lot of persons they know that they have traces of cancer in their family. But in many instances, they're scared to come forward, yes, but also that the cost sometimes of getting the genetic testing can sometimes be a bit prohibitive. So I just want to, that's the concerns I'm hearing raised. I don't know if we've addressed it fully in terms of access to genetic testing and the speed at which it can turn around. But I hope that that is certainly on the cards if it hasn't already been considered. And then as it relates to the PET scan machine, obviously, we've been talking about this for quite some time. It's almost like talking about the incinerator or the linear accelerator. We know that these are pieces of equipment that can help save lives, that can do the necessary interventions. Many people who are able to have the PET scan machines oftentimes have to go overseas, which again is a cost to government, is a cost to individuals, and sometimes it is out of reach for the most vulnerable in our society. So whether it is that if we are looking in that direction, I would like to know whether private or joint partnership, or whether we're able to leverage on the relationships with other territories that have these machines to be able to ensure that people have a chance of being able to survive.
Thank you. We are looking at PET scans, but not right now, not at the immediate. I think that is the one that they're more likely to get a joint venture because certain entities, a lot of insurance companies have to pay for people to go overseas, Miami or Puerto Rico, for PET scanners. So it is certainly something in the QEH expansion that I spoke about, where I spoke about an ontological center. There is provision in there for PET scan. In terms of immediately, right now, we have not focused on that at this point. Oh, sorry. The other question is about DNA typing. We are now, I guess, in the embryonic stage. You would have heard Dr. Becker speak about doing genotyping, as that relates primarily now to transplant surgery. But you've heard me speaking also about the living lab, which is expected now to go into that aspect of DNA typing and stuff like that. And then going to recognize that a number of these cancers have their origin in genetics. But that is looking at the Barbados Living Lab in conjunction with the Best of Santos Lab. But we're also preparing for that. Again, we will need a number of young scientists, and we're looking at this. And I'm hoping to have the structure finished and outfitted, and then we have to get additional posts for the Living Lab. And we'll be looking at young people, interested in research. Thank you.
Without prolonging much, Kenneth George, PAHO is assisting us with the genetic piece. Actually, Sanji may be able to give a quick update. She has been invited to a workshop where we're trying to build out the capacity with respect to the Best DeSantis Public Health Laboratory. And why this is important also is that as we move towards the living lab, these areas will need to be discussed much more in much more detail and the investment given.
Good afternoon. Dr. Sanji Beckles, Director of the Best DeSantis Public Health Laboratory. With respect to genetic testing, Minister, we do see that as a very important part of the testing in terms of follow-up and monitoring, not only of persons to identify if they're at risk, but even to determine if they're progressing and if they're responding well to treatment or when cancers are actually reoccurring. And as a part of the Living Lab, the whole purpose of the Living Lab is for research. And it's, in my mind, it's living, and we are supposed to be dealing with things that are current and respond to the things that are important to persons in Barbados and outside of the region as well. And cancer diagnostics is one of the very important areas that we want to get into. As the Minister did rightly say, we are in embryonic stages. The building is under renovation right now and should be completed, hopefully, within the next few weeks. We have procured some equipment already and do have some in this year's estimates to procure some equipment for that testing, including the genetic testing. To be quite honest, one of the first markers based on our expansion of colorectal cancer, one of the pieces of equipment I identified can help look at some of the genetic markers to respond to that. But of course, that is only one of the many cancers in Barbados that are of concern. and we would endeavor to also break out into other areas and other tests to be able to capture genetic testing for all the cancers of importance in Barbados.
Thank you.
Thank you. Honorable Minister, you can wind up and then move that the head stand part.
Thank you, Mr. Chairman. I want to thank you and the honorable members of Parliament for accommodating the staff of the Ministry of Health and Wellness, Minister S. Marshall and myself. Over the last almost 2 days, as we responded to your questions, we were pleased to be able to respond to your questions, which were many and varied, and we were delighted to inform you and explain to you what was happening with the plans for the Ministry of Health and Wellness going forward. We recognize that there are several deficiencies within the Ministry of Health and Wellness, but we are working assiduously to rectify a number of these. Oh, sorry. I thought I had said the Ministry of Health and Wellness. I thought I had mentioned it, but I'm told the entire team of the Ministry of Health and Wellness. Well, absolutely, I thought that was. Okay. Now I've lost my train. Anyhow, I want to thank you. I recognize that we have some deficiencies, and we will be working as seriously, me and the entire team of the Ministry of Health and Wellness, to deal with those matters. But also we need the support of my colleagues, my ministerial colleagues in the various ministries, and certainly the support of all the members of Parliament in achieving some of our goals and our aims. And I certainly said, I can't say it was a very interesting period. I missed some of the members, in particular, one member today, and I was looking forward to further briefing him and perhaps elucidating matters for him, but unfortunately, he wasn't here for the entire day. That's it. I just want to again express my appreciation for being able to be here with my team to speak to you and to respond to your queries and your questions. Thank you, sir.
Mr. Chairman, I beg to move that Head 86 stand part.
The question is that Head 86 stand part. All honorable members in favor, say aye. Honorable members against, say no. Methinks the ayes have it. Honorable Leader of Government Business.
Mr. Chairman, I beg to move that you do not report progress to His Honor the Speaker and beg leave to sit again.
The question is that I do not report progress to Her Honor the Deputy Speaker and beg for leave to sit again. All honorable members in favor, say aye. Honorable members against, say no. Methinks the ayes have it.
Honorable members, your chairman has reported progress and has asked to leave again.
Madam Deputy Speaker, I beg to move the House be suspended until 3:15 p.m.
3:15. The question is that this House be suspended until 3:15 p.m. All honorable members in favor, please say aye. Those against, please say no. We think the ayes have it. This House is now suspended until 3:15 p.m.